Let me introduce to you our panel here this afternoon. I have Craig Brammer. For those of you that were not here this morning, Craig is our Beacon Program Director from DC at the Office of the National Coordinator, and a great colleague and friend, and he is a Cincinnati native. He's part of the senior leadership team at ONC for working on health information technology and serves as our Beaconista leader. For those of you that don't know a lot about Beacon, but I think you've heard a lot about it today, it is an innovation portfolio funded by the Office of the National Coordinator for Health IT that was backed by about $250 million over 17 diverse communities, including Cincinnati, where clinicians, hospitals, and health plans and other partners are testing novel technologies for leveraging health IT to drive improvement in healthcare. And David Ehrenberger, those of you that met David this morning, is the Chief Medical Officer at Avista Adventist Hospital, an integrated physician network in Denver. He was one of the early persons in my Beacon journey that inspired me. We went to Denver for a conference, and I thought, I need to get to know that guy. I don't know if you knew that, David. He has 7 years of experience leading clinical integration collaborative through North Metro Denver. He's a board member of the Colorado Foundation for Medical Care, which is the state's QIO. He is around a lot of work around patient-centered medical home, and he's the vice president of Team HealthWorks, which is a Colorado QI group for a successful multi-stakeholder, multi-payer PCMH pilot, and he's a partner in a 14-provider family practice recognized as a level 3 PCMH practice. And Dr. Robyn Chatman is right next to Craig here. She serves as our medical director here at the Greater Cincinnati Beacon Collaboration. She is our board-certified family physician and the fellow of the American Academy of Family Physicians. She is an active as delegate to the AMA, the OSMA, and is president-elect of the Academy of Medicine here in Cincinnati. And lastly, Dr. Mansour, down at the end of the table, is the Associate Professor of Pediatrics and Director of Primary Care and School Health Services under the Division of General and Community Pediatrics at Cincinnati Children's Hospital. She has a long-standing interest in improving the health of children, especially for children in underserved backgrounds. She's been a leader for multiple quality improvement initiatives with primary care settings, such as primary care clinics and school-based health centers. Dr. Mansour has a long-standing interest in asthma and is currently the leader of the Asthma Improvement Collaborative and serves as the key leader from Cincinnati Children's Hospital under the Beacon work, leading the regional transformation under using the ED and admission alerts and the registry functionality that we've done a lot of customization for her asthma population. So I want to welcome our panel. And the purpose of our plenary session this afternoon in closing this great day is to foster discussion among our panelists and the audience on the topic of a path to exceptional care. We've talked a lot about what we think exceptional care is. We've got some questions that we've teed up, and I also hopefully that you'll come forward and ask our panelists some questions about your thoughts about exceptional care, the challenges and the successes that you've all had. I've had an opportunity to work with a tremendous Beacon team over the last 14 months and building additional stepping stones to our community towards our exceptional care journey. And I've had the privilege of working with all these providers and redesigning a system of care that has been a lot of work. I've noticed there are some similar characteristics. I walked through several of the sessions today, and I wanted to just pause and reflect on some of the exceptional providers that I heard that had common themes when I walked through the sessions. What do exceptional providers say they do? They decide that the time is now. And what we all know is this culture change is difficult for every one of us sitting in this room. No more need for pilots. Exceptional providers know everything they need to know to get to work and do it in short order. And the most important thing, I think one of the most pressing things that gets me up every morning to go to work is they put their patients first. Every decision, every change is about how to protect, preserve, and enhance the well-being of the people you care for, with a special consideration for the marginalized and the poor and disadvantaged. I heard Dr. Singh talk about the patient advisory group to his practice. How, we used to think 5 or 10 years ago how novel that patients might tell us what we need, but there actually are advisory groups advising physicians and provider groups on what they want from them. The team, the primary care team in the office and the practice is really unparalleled in really making this work. It's about changing up what we think we have known, what we know about exceptional providers, that they need both internal teams and external coaches and guides. And I think that's what success is about with these exceptional teams. What else do? We look at the data. I heard that over and over again today as I walked through the different sessions. Assess honestly where we are, what our successes are, and what our failures are, and what our opportunities will be going forward. They gather data on their performance and figure out where the biggest gaps in care are and how we can provide better care for our patients and our families. They use technology to support the change. They use EHRs, HIEs, the registries, all these clinical decision support tools that Beacon has funded so we can go on to support and enable change over the long term. So the idea is not just doing the work, but sustaining the work over time. We improve. We know about quality improvement, but we've met the intersection of quality improvement and health information technology, and we're never going back. As much as we all would like the old days and have little pockets of quality improvement and little pockets of HIT, I don't think there's any turning back, and I'm proud to say that this community is on the path to make that happen. And one of the things when I was listening to Don Berwick's opening session in his 2011 IHI opening remarks, he said, one thing that exceptional providers do is they return the money. And I think this is the thing we don't talk a lot about and we don't like, but they understand that those who pay the health care bill need to see their bills go down as care improves. And what we now know is that cost up front for this transformation is expensive, but what our imperative over time as this improvement accelerates is to prove that we can accelerate change and decrease cost. And that's probably the least sexy thing that we'll talk about today, but an absolute imperative as we continue this work. These are all courageous steps for all of you. This is really, really hard work. And I think Dr. Singh noted that during his panel session, he said how difficult the work is. I can honestly tell you this has been probably the most difficult challenge I've ever had as a professional, but one that I wake up every morning and think we've got to persevere. So now I'd like to turn to the audience in a moment and ask you a few questions. But first, to get the conversation started, I'd like to ask our panelists a few questions. So for all of you, based on the conversations you had today, what do you see as the essential steps for hospital leaders, practice leaders, and other stakeholders working to transform care? Who would like to open that up?
Go ahead, David.
I think the most essential step, and I feel like I'm preaching to the converted here because, the Cincinnati area in this initiative in particular basically has already done what I'd say. So I'm done. No, but you're collaborating. You have healthcare leaders from multiple stakeholders in the same room, in multiple collaborative organizations, addressing smartly the different facets of healthcare transformation need to be addressed. And so that's job number one, finding a room that you can lock and get, put the people in that need to collaborate, and then lock it and don't give them a bathroom break until they figure out where their overlap of their Venn diagram or common interests are. So that's one thing. Second thing is physician leadership, and I've met a lot of physicians just today who are doing just that, who are stepping forward and learning the skills of leadership that aren't taught in med school. And that's, I think, very powerful. Then the final thing is we need to, I think in healthcare transformation, innovation, we need to keep our eyes on the ball, and that is that we're really after creating what I like to call market-relevant value. And so that means, it's another way of saying give the money back, but provide a product that provides that kind of exceptional care value at a lower premium.
I was just going to add a little bit around the idea that, within organizations, you really have to create, we all talked a lot today about, change of culture and getting sort of paradigm shifts about the way we think about care. But I think we also have to create cultures where it's okay to fail in the context that you learn from those failures. And so I think not only do we have to build will amongst, our practices and the people that are working within those systems, but you have to be okay to be willing to try things and to innovate and to recognize that every idea that you have may not be a success. If you don't allow people to try things, then you won't come up with, with solutions. And then I think the second thing, I missed the morning, so it's because I was seeing patients, but I think the second thing I really think about is we really are moving toward, this concept of team-based care, and we keep talking about provider incentives. And so we really, I think, if we're going to be creative and successful here, we need to think really about team-based incentives and how hospitals or systems incentivize the team, because I can tell you one of the biggest challenges is, engaging everyone on the team to be part of the team, and we don't get it done without everybody else on the staff helping us to achieve that. And so if you pay me more as a physician, great, but that doesn't incentivize my team to do the work differently.
I think one of the things that I would suggest as a concept for hospital leaders is the idea of the data belonging to the community and using the data to compete for improvement and not competing one institution against another, but using the community's data so that we compete to improve care, so that the competition is how can I do a better job of taking care of our patients. So thinking of the data not on an individual basis, although it does belong to the patient, but thinking of it as community data, and that we compete with it instead of for it. I don't think that's a new concept, but I think certainly the implementation of just that thought, that the data belongs to the patient, and the patient is all of us. It's our community, and that again, we use that data and we compete with it and not for it, and that this is truly a community enterprise. We only are doing as well as the least of our population. We're about to bring a large number of uninsured folks onto the rolls in the next couple of years as a result of health reform, people who need that care, and we need that data to provide them with an efficient level of care and making sure that the care that they're going to be getting is the highest quality that we can make it.
Yeah.
I'll just add that I always wonder what people think when they come to Cincinnati. Like, it's interesting to get your perspective because, the word collaboration is just pervasive here, but it's not like it's all rainbows and unicorns. We're not asking people to hold hands, and these are smart business people who have business objectives, they have patient care objectives, and they've just identified corridors of collaboration where it makes more sense to do it together than not. And a little example, but it's non-trivial, was just today, this event. I just heard David Groves do a really impressive analysis of the Stage 2 proposed rule. Most people in America, you got to go read the Federal Register, the 900 pages, if you want to get any kind of analysis of that, or try to surf the blogs or whatever. And so people in Cincinnati are fortunate. They've come together, they've said, we want to stand up an organization that really focuses on health information technology, and they're the experts. And so they have, a sort of a shared consulting firm here that I think is really impressive. So it's collaboration with a purpose, not just because we all like each other, although I like Keith, for example. He's a good guy.
Yeah, those are great points. I think we have come together for a purpose, and we have worlds that are come together that would not necessarily have come together 5 years ago. We speak different languages, we live in different environments, and the cultural change has to happen at every organization, not just among the teams. And I think that's been one of the biggest challenges for us in this community is, we have our work of the day, we have our cultures of the community, but we also have the culture within our organization. So it is challenging, and I applaud all of you that are sitting here in the midst of all of this. The one point I wanted to make, that Mona, to comment about the failure. I think one of the things when I started doing this improvement work years ago was that, the PDSA, the study and the act, adopt, or abandon, were pieces of that we forgot to do. So studying what you did, and then feeling bold enough to say, this isn't working, and starting over. And it's okay for all of you that feel that, you may not be making headway, really the studying and then adapting, adopting are really your best steps, and don't forget those, because I think that really helps you understand what you can learn from your failures. So thank you, panel, for your comments. We spent most of the day discussing healthcare improvement. Can you share some of the ways that each one of you have put these steps into your practice, whether you're a government type or a practitioner?
Go ahead.
Yeah, I'll comment on that because it's actually one of my favorite topics. Seriously. So it's been a journey into failure for me. Thank you very much for that insight. But good failure, because you learn from it and then you move on. It's been a paradox for me as a physician and growing up professionally in a culture that just loves data, quoting New England Journal of Medicine articles, whatever, that's what you're taught to do from square one. And yet, the moment you start talking about a physician's own performance data, you get the door slammed in your face and you're treated like a communist. But to add paradox to paradox, one of the things I've observed is that physicians and providers practices love their performance data. They absolutely love it, but only in one circumstance, and that's when they own it. Otherwise, they hate it. So, with all due respect to United Healthcare, I don't know if anybody from United Healthcare is here, but if you show a physician the United Healthcare data, they will hate it, hands down, because it's almost always wrong. And so they have reason to hate it. So when they see their own data generated from their EHR and maybe presented from a local healthcare collaborative, they'll still be suspicious. But it's a great opportunity to engage providers to allow them to be suspicious of their data and to challenge them to prove it wrong. And if they prove it wrong, learn from it as a purveyor of data. You say that your organizations produce data for the providers, and if they discover the data is correct, then they'll love it and they'll buy into it, and that's kind of part of the culture change, is to engage providers around their performance outcomes data. And share it with them and give them the mic and allow them to challenge it and explore it and do the validation themselves. Because once they are hooked, they're hooked. They're in the game.
I guess we're going in this order, huh? I guess we've done a lot of things to improve asthma care at Children's, I think one of the core pieces that have been at the core of that success is really engaging people on the team that represent sort of all aspects of whatever care process that we're trying to improve. So whether that's the work that we've done, for example, on ensuring patients leave the hospital, ready to manage their asthma care at home, so making sure they have the medications in hand to manage their asthma, care plan that helps the family manage that and know what they're doing at home, or whether that's a home health pathway or care coordination models that we've put into place. We've sort of made sure that we have, all the stakeholders sort of involved, so that you can sort of see that process from a variety of different angles, and hopefully mitigate some of the failures in the process that you wouldn't pick up if you didn't have key folks involved in those, and that obviously includes families as well.
Well, my practice setting is a relatively small family practice office. At a time we had 3 docs, and we were fortunate enough to have our own data, and I talked about competing with the data instead of for it. Docs tend to be just a tiny bit competitive at their very nature, and every month when we looked at our numbers, there was a little competition between the 3 of us as to who had the highest number of diabetics with hemoglobin A1C less than 7, and if you were the lowest doc, you didn't want to stay the lowest doc, so You looked at what the other two docs were doing to bring their numbers up, and if you wanted to even exceed them, you'd call another office and say, hey, what are you guys doing? And before we knew it, what we had were some best practices, and we were all doing well. So that's a very small version of the competing with the data that I was mentioning earlier. I'd love to see that on a larger scale. But we were designated as a level 3 NCQA patient-centered medical home, and I'm not going to tell you it was easy. It was like making sausage. The things that we had to focus is, because again, docs like data, they like detail, and we started off getting really, really focused on checking off boxes, and we don't have the kind of patient population that will let you ignore them. So they kind of helped us remember that it is indeed a patient-centered medical home. So we had to regroup on our twice weekly meetings about, yes, this is a requirement that we need to meet, but it also needs to take care of the patient. So that took the onerous nature out of the requirements for us, because it was just a more efficient way of taking care of our patients, which is our primary job. And it was not unlike the focus that we gave our staff when we started the practice in the first place. Our job is to take care of the patient. You have a job, you answer the phones. You have a job, you bring the patient back. I have a job, make a diagnosis and a treatment plan. Can I answer the phone? Sure I can. But is that the best use of my skill set? No, it's not. So that empowering each of our staff to function at the highest level of their license became a new way for them to provide our primary goal, which is to take care of the patient. So it didn't seem so onerous after we got over the enormity of the task. We just turned it into what we were already doing and worked a lot harder at it and at organizing our effort. I think the next step in patient care and in PCMH and in health reform, I think, is improving the patient's accountability. I think the employer-sponsored plans are onto something. The fact that they have you, if you get, it's a point system, you go to your doc, you get your physical, you get so many points, and that turns into a discounted rate on your premium. I think that's going to be critical in how we provide care going forward. And I'd love to see that expanded beyond just the employer-based plans, so that the patients have a scorecard, so that they have a vested interest beyond just being healthy, but having that vested interest in their health care. I think that's going to complete the circle, because health care is provided on a team concept. It's the doctors, it's the nurses, it's the front office staff. But again, this is a patient-centered medical home. So I think that patient accountability is a big part of the next step.
Patty, I'll give you maybe a quick glimpse into the ONC and try to answer that question. How do we imbue QI stuff into the work? Interestingly enough, the former national coordinator, Dr. David Blumenthal, he was not an IT person. And he was a very impressive national leader. I used to assign my graduate students to read your Blumenthal before I ever had met him, and so it was really neat to work with him. But he was not an IT guy. And he recruited most of us that are there, and a lot of us are not IT people. And so I'm more comfortable in the QI space, in the measurement and the payment world than IT. I'm learning a lot. But so there's actually a lot of quality improvement kind of methodology and thinking that hopefully is evident in the stuff that comes out of ONC. So even the meaningful use rules, those are really driven by logic models of what would it take to actually improve patients with CHF, improve care for patients with CHF, and then map backwards into the into the specs. So anyway, there's a culture of improvement at ONC that I think is really terrific, and hopefully it's evident.
Thanks, Craig. You answered my next question. I got to it. So good. So these next two questions before we open up to the audience are directed at two of the panelists. David, this one's for you. So healthcare professionals can feel pretty overwhelmed by all the changes that are happening, all the acronyms that we threw out today, and the government requirements. How should physicians and practice administrators and nurses and advanced practice nurses view the changes that are happening in healthcare? Are there ways to get ahead of the changes to not feel as if they're being done to you? And lastly, what roles do physician leaderships and regional collaboratives play in helping the private practice community not only survive these times, but thrive?
Well, that's an easy one. Thanks, appreciate it.
Sure.
And I'm glad it had 3 parts so I could remember them all. Well, in terms of getting ahead of the game for physicians and nursing and other practice staff in the community, and not feeling like we're being overburdened, that's impossible. But I mean, this is I think it really is kind of leadership 101, and it's community leadership 101. Kind of the notion of community, or maybe collaborative leadership for community benefit. It's about I think in order for it not to be a burden or minimize the burdensome nature of things like Craig is imposing on us, sorry about that, is to sell it, spin it, paint a picture of the future that is more compelling, because as has been mentioned multiple times today, the benefits of practice transformation as a essential building block of healthcare transformation in all facets, including staff and physician satisfaction, are indisputable. But there's pain to that gain, and only way to get through the valley of pain, or as one physician called it to me a couple of years ago, the valley of stool. Can't believe it. But nevertheless, okay, well, that's very descriptive, thanks. But is to, docs, that's what but very scatological. But, try to paint a brighter future, and then, of course, the burning platform thing. But the critical thing is defining the first concrete, relatively easy steps. And so I would say that things like striving for meaningful use is kind of a first easy step, because it's concrete, it's specific, and if you have great local resources, you can start to take it. And some people will go to PCMH first, some people will do both at the same time. But I think ultimately the answer to your question is there's no easy way out. It is about leadership internally in the office, leadership in the community or healthcare organization, and it's classic change management.
Absolutely. Thank you, David. Mona, this question's for you. Mona Mansour happens to be one of our lead Beacon physicians here in town, and she's been tackling a lot of the issues about fragmented care. Care transitions and care coordination are key strategies for our Beacon work, and also in attempting to deliver lower cost care. Mona, you've been leading a new care coordination effort at Cincinnati Children's under the Beacon work with your high-risk Medicaid patients. Can you tell us a little bit about the model of care and some of your key successes and challenges?
Sure. I think, obviously there's been a lot of conversation around how doing transitions of care better is one of the ways we can bend the cost curve. And I think one of my, sort of worries moving forward, we'll have care coordinators of the care coordinators or something, and we'll all be tripping over each other. So hopefully as we sort of roll these things out, we think very critically about how we do them. But we have been implementing a care coordination bundle for high-risk patients that have children that have asthma, kids who have either been admitted to the hospital within the last year or who have had 2 emergency department visits. And we have been following a metric called time between failures, which is looking at the time between ED visits and admissions for those patients. So at baseline, essentially, they would visit the emergency department or go to the hospital about once every 173 days for care in one of those locations. Through our care coordination bundle, we've been able to push that out to about 275 days between those events, which if you think about the complexity of some of the patients we're talking about is a pretty big accomplishment. And obviously, we're working on some cost savings and sort of looking about what that translates into. But even simple math will allow you to translate that into cost savings for the payers. We've done that through a bundle of interventions that really key around a couple things. One is risk assessment, a second is self-management assessment, and the third thing is building community partnerships. So as I imagine many of you could see that the majority of the patients' issues don't have anything to do with their medical care, but it has to do with the non-medical needs that have to be addressed before they can even begin to focus on their child's asthma. So those sort of 3 key components allow the care coordinators to really have a better picture of what's going on with the family. And then really the other key, obviously is building a trusting relationship with the family and being able to sort of navigate that relationship. But it's been incredibly rewarding to watch and see, both the perspective from the care provider as well from the care receiver, in this case the patient and their family. I think they really have reaped some pretty significant benefits from that.
That's pretty remarkable work, Mona. You're almost 100 days between events from where you started to where you are now. Congratulations.
Yeah, we just started thinking about some because we have a limited resource. We are working on ways to engage payers to pay for this work, but we only have, and if you really want to have the work done, they're in the back of the room. But we finally had to sort of set goals for graduation from care coordination. So we do actually have now, I think it's 31 kids, maybe today it's more, that actually graduated, which meant they went 365 days without failure, and so that we can sort of move those children out of care coordination and move new children in.
Yeah, awesome work. Thanks, Mona. Robyn, this question's for you. You've been through the implementation of an EHR. Now, I know you have a little geek factor, so you have to talk slowly for those of us that don't have that geek factor. But applying for meaningful use and getting certified as a medical home was a real accomplishment. How did you manage all the requirements while you were still seeing patients? And what do you see as the next steps for improving care for your patients now that you've taken these steps?
Sure. Again, I think it's, again, remembering that the patient is at the center. The staff did go through some growing pains. They looked at the requirements, and we actually have a big chart on a wall that's in the staff part of the office, not where the patients can see it. And it is it's 8 feet long and 5 feet tall, and it contained all of the requirements. And the staff literally just they were almost internally combusted. They just thought it was just overwhelming, and we really did have to kind of bring them back and say, okay, what's our primary goal? They said, take care of the patient. Okay, so we literally just kind of broke each component down, and the person that we had earmarked as our patient care coordinator was the LPN in our office, and she said, well, how am I going to do this and take care of patients and put all this stuff in the computer and go to all these meetings? And we listened to that. We actually divided her role into 2 parts. She's still the patient-centered medical home coordinator, but we divided the other part of the data collection part into a separate position. So we took one of our medical assistants, and she focused on the data collection. And as I mentioned before, how my partners and I would look at our numbers and say, okay, well, I got to beat her next month, It got to be quite a office kind of, I won't call it a pool or a party, but the person who puts in the data, I found out that one of my partners was was bringing her donuts and coffee to get the numbers early. But I guess the bottom line was, again, the patients were, there was a motivation, whether it was donuts and coffee or whether it was the internal motivation to have good numbers, and the numbers were the patients. So, again, the key being never forgetting that those numbers have people behind them and have lives behind them. And we had to do also kind of what Mona was talking about, was looking at, and it's kind of the nature of family medicine, but again, you can't get so caught up in the numbers that you forget that, if that person loses their job and they don't have access to their medicine, then yeah, when they come in, their blood pressure is going to be higher, and you might have to change their medicine to something that you got samples of, so that you can bring those numbers down. So again, we did have to, you had to look at the whole patient and again, rally the staff around the cause, which is better care of the patient. Again, next steps, again, I do think it's patient accountability, that they know that we're watching the numbers. And in Cincinnati, I don't know how many of you have seen the website, Your Health Matters, where doctors are actually publicly reporting their data. And I'd have a particular patient that was, I try not to call them non-compliant, but they have other focuses besides taking their medication. And as a default, I would say, okay, you're going to make me look bad. And that got their attention. They didn't want to make me look bad. They didn't want their numbers to impact how other people viewed me as a physician. And I'll be darned, that got half a dozen or so people to work on their own care a little better by exercising a little bit more, by skipping the dessert, and making sure that they took their medicine. So I think that patient accountability is a big part of it.
Hey, how do you know that bribe wasn't to actually increase the scores of your partner versus get him put in faster? I'm just curious. You might check into that.
Well, great. Thanks, panel. Now I'd like to open this up to the audience and see if any of you have any questions for our panelists or for one another. I think we've got microphones placed throughout the audience, so please step up to the microphone so everyone can hear the question. So I'd like to open it up for any questions, comments. These lights are a little glary, so I can't see everyone. Oh, good. We've got some people coming up to the mic, some brave souls.
That would be me. I have a question for just about everyone. How do you motivate your staff and keep them on task? Because everything we ask them to do just adds one more item to do what they are already viewing as an overwhelming job.
Great question.
I think that it's a sort of continual work. But I think, some of it is, one, staying patient focused, and I think, to what Robyn was sort of saying earlier, really sort of focusing on the patient. I think the other thing is, we talk a lot, we've had a lot of success in our primary care environments, sort of being what I call a level 1 reliability system. We do a lot of things well, and we've gotten to that level of reliability because the team has done great work to get us there. But I think, I think it's sort of building that sort of sense that, we haven't gotten there yet. We really have so much more to do to improve their satisfaction, in terms of patients, and our satisfaction around how care is delivered. And I think they can all still see inefficiencies in the system that we have. So I think it's sort of reminding folks that, it's a journey, and that we have to, that part of our job isn't necessarily for them to be working harder, but it's for us to find systems, that it's not sort of failures in them as individuals, but it's a failure in how the system is performing. And so we need their input to change the system, so that, at the end of the day, again, I think there's, at least in our environment, there's always going to be more patients. There's always going to be plenty of people to come. So I don't think we're ever going to get, stop people sort of coming through the door. The demand will always be there. But I think we want to enjoy what we're doing more and make sure we're delivering the right care to the right patient at the right time and in this environment at the right cost.
I kind of alluded to, how we incentivized our staff beyond the donuts and coffee. But as providers, we met different milestones, we kind of had little celebrations in the office. So the achievement of a milestone was a group accomplishment. So as we set those milestones, we got to one, then yes, we set the next one a little bit higher, and it was, and we just incentivized the staff to, if we get to this next milestone, then, the docs pay for lunch at, wherever, or, you get an extra half a day off, at some kind of low volume time. So we involve them in the setting of the milestones as well. So it's, again, that I can't emphasize the team approach enough. Even though each individual physician was being measured, it was a function of how well the office did and how we as an office staff functioned. So when we met a milestone as physicians, we made sure that the reward included the staff as well.
So some celebration along the way. Good.
Yeah, so maybe I'll just comment on that. First of all, that one thing we did not do was pay for performance because we didn't think it was effective in the literature. One thing we did do was to acknowledge that much of practice transformation or the evolution of practice requires, in many instances, more staff. So one thing we did, much to the chagrin of my senior partner, was to increase our staff, not a lot, about 2 FTEs, to offset some of the extra work that's required. The second thing we did, which was much more powerful in many ways, is to figure out how to allow or engage our employees in 2 things that were critical, and that was, one is have them participate in patient care. And for instance, in the case of population management, if you will, or using registries, that's not a job of an RN or a mid-level or a physician. It's a job of somebody who used to work in our chart room back when we had paper charts. And now the main job is focused on managing, updating the registry, contacting certain categories of patients who need care coordination and get patients in when they need to be seen. And then we share data, quality data, as a group. So it's more of a team effort. So we have a game plan as a group to improve, say, the care for people with asthma. And we share data on a regular, predictable basis. In the conference room we have downstairs, and post that data. And so we involve not all of our employees, but most of them in some aspect of kind of top-of-license care. So that's a valuable experience still. I mean, people really dig it. They dig not just checking people in as their main job or taking blood pressures. Second piece of that in terms of engagement of staff and making this change in how things are done is to try to involve as many as possible in our performance improvement efforts or teams. So we actually have 3 teams, and predictably they are triple aim teams. So we began with the quality, we have a cost team, we have a patient experience team. And so those are designed so that there are different members for each one, and they have one of the 3 actually has a real live patient on it. We haven't gotten to a patient in all 3, but they definitely have front office staff, all the process or patient touchers are involved in those teams. And it's incredible what you learn about that and how the insights of people, in the Toyota model, if you will, frontline workers, give insight into processes and enable us to improve the way that we do things. For instance, we're trying to improve our mammography rates, and we saw that there were a lot of people who just don't get them done, even though for various reasons, and it turns out they can't get them done because they forget and because they're busy. It's like very human stuff. So we're trying to figure out how to remind them without yet burdening our MAs, who usually track that kind of stuff, more. And one of the MAs came up with this idea that we would just offload that work to our local hospital that was doing most of the mammograms, and have them do the reminder work for the patients. And that worked extraordinarily well, and it decreased the MA's work. And there was a feedback in terms of participating and not being a victim of the changes of the office, but participating. It's just one example.
Hey, Patty, let me just tell you real quick something I saw. Well, first of all, so I don't work in a practice, obviously, or setting, but for our team, we have kill meetings. This is a kill meeting is where you sit around as a group and you kill something off. I'm a big believer in creative destruction. So we build up these programs, we add new stuff and layer. And so whatever comes in, you got to take the equal amount out. So we literally as a group decide, all right, that worked pretty well, but the input cost was so high that we're going to kill that off. I don't know if that applies to your setting. But here's what I was going to say is I have traveled around America here in this last 2 years in this job and seen some really interesting and crazy places. In the Mississippi Delta, there's a little hospital called North Sunflower. And it is got the award of one of the most top-wired critical access hospitals in America. And these guys have got this place dialed down. It's a former catfish farmer who's now the CEO. He retired. I mean, it's just, it goes on and on. It's just crazy. So I'm going to make a point here. Hang on. So when you walk into the lobby of this little hospital, there is a life-size Elvis Presley cutout with a guitar. And every time they meet a new meaningful use element, they would move a marker up the frets of the guitar. And there was something about them, I mean, that was hilarious, obviously, and as far as I loved, I took a picture and texted it to him, but there's something about telling your patients, here's something really hard that we're working on. And so it's great to have these dashboards back in the conference room where your team sees them, but I'd put them out there. I would say, this is a challenge we're having, and we want you to know that we're working on making this practice or hospital or whatever better. I thought it was pretty neat. A little North Sunflower. By the way, their readmission rates are beautiful.
The only other comment I would add is the other technique that we've used is, you can do this in a couple different ways, but, walk the walk of whatever process you're trying to improve. So, for example, we were working very hard to improve patient flow within our environment. Of course, everybody was pointing to somebody else. It's, the registration people, I don't know what they're doing up there, and it seems to take them forever. Why is the patient in the back? Oh, I see you on Facebook, you're not doing, it was, everybody wanted to point it to somebody else. So as part of the improvement work, we actually, made people, in each of those roles follow a patient through the process to sort of have appreciation. And I think, one of the things we ended up doing was moving our registration staff, out of the front of the clinic, and they actually started registering sort of in the back of clinic. And I think what everybody sort of realized was, it takes a little bit longer to register a patient than you think. It's under certain kinds of circumstances, so that they're not out there eating bonbons, doing something. They are actually registering patients. But it also gave us opportunities to see where there are potential wastes in the system by sort of walking the walk. So it's another, and I think that also then everybody started to realize again that piece. It's not me or you or that you as a person, but it's this system that we have of how we work together as parts that was very instrumental in getting, did that move everybody, but it got enough members of the team sort of saying, oh, that's, we could do this better. We don't do this very well.
Yeah, great comments. Do we have other questions from the audience? That was an answer to one question.
As you have experienced these culture shifts in your respective settings, what approaches are you taking with hiring and selection so that new folks you bring on are adding to the momentum?
Yeah, I think one of the sort of key things as we're sort of hiring individuals is really sort of looking at, I don't know if you want to call it a sort of innovation or flexibility factor, but I think the idea that, especially at Children's Hospital, you know, there's obviously been a big culture change in terms of sort of the whole broader institutional environment. So we get a little help from that in general, but I think especially also in our primary care environments, we're doing a lot of improvement. So I think part of the issue is, you know, people, you know, recognizing that we need to hire people that are comfortable with change and sometimes pretty continual change. So I think it's part of sort of what we, you know, some of the sort of interviewing lines of thinking is sort of figuring about the rigidity or flexibility of individuals and willingness of those individuals. Obviously, more and more it gets harder and harder or easier and easier depending to hire people that have come from an environment with quality improvement experience because, you know, everybody's looking for the same people, you know, from that standpoint. But I think it's sort of looking more at characteristics, you know, in addition to the skill sets that are important.
One more comment from each one of our panelists to wrap this up. Any key hiring strategies?
I have to confess, I hang out in the back. I try to stay as far away from my manager's office as I can. But one of the things that I have noticed that she's done just a little more often lately than previously is the utilization of, I guess, the temporary services and folks that are in those environments are, sometimes they've got a part-time position and then they come to us for the remainder of that time. And we've been able to find folks who have had some experience with an EMR. So that makes it a little easier for us because somebody else kind of finds them for us. And then, you know, when they get into our system, we try to add, you know, give them a key role that they focus on, and then we can add responsibilities going on. And using that approach, I think that's where the last 3 people that we hired on permanently actually came from. It doesn't work for everybody because it's a little costly on the front end, but that's just a trend that I noticed in our practice.
I would just add to this that we try just to be really clear about that when, let's say, an MA is hired in our office, wants to be hired, it's not a typical job for many MAs. And so we talk about some of the atypical expected duties, if you will, such as learning how to do motivational interviewing. It's important for us in how we address several of the chronic conditions, patients with chronic conditions in our office, that motivational interviewing becomes part of what we do as a patient engagement strategy. And most of that's done by our MAs and not by providers. And so that's usually very foreign to them, and they usually we just invite them to watch the process. So that's one thing. Or we talk to them about how we use scripts to address other parts of the expanded job duty, such as we often talk about the number 1 job we have in our family practice is to help people quit smoking. And so, of course, we consider it a vital sign, and we don't miss an opportunity to address it, la-di-da. But the MA's job is to assess whether somebody is a smoker, and if they are a smoker, to actually begin the process of advising a patient that it's our interest to help them in any way possible to quit smoking, and are they ready to entertain that. And so we have a script for our MAs, and so are they interested in participating? So we get an idea whether or not they would fit, and sometimes they just don't want to do it. They just want to come in and do their job and leave and not participate in these kind of things.
Okay, thank you.
Most people like it.
Thanks, David. I have one comment about that. When we were doing a lot of clinical transformation, a great book, leadership book called First Break All the Rules, and it talks about how you hire for attitude rather than skills. And I would suggest you look at that, because when you're doing transformation, attitude is 90% of the effort in creating an environment of transformation. I found it really helpful. So thank you to our panelists. This is a great hour. It went by very quickly, and I want to thank the audience for hanging in with us Friday afternoon March Madness. I have a few closing thoughts. At HealthBridge, we would love to continue to foster this regional-wide discussion about health IT adoption, and also with about healthcare transformation and all the work that we have ahead of us. Keep up with the activity post-conference through your Twitter, Facebook, and LinkedIn. This is per Trudy, our wired communications person. More resources will be available through the tristaterec.org site. All slides and recordings will be posted to this website after the conference. A few more housekeeping things. Please turn in your evaluations in the spirit of continuous improvement. We'd like to really turn this next year conference into something even more helpful to you. Thank you for your help with that. And last, turn in your passports for the drawing. For the iPad. Trudy's got it here. I think we're going to do the drawing now. And I think that's all. Did I forget anything, Trudy? Am I good? Thank you, everyone.